So this part of the video, I'll be discussing the topic development of kidney along with the congenital anomalies associated with the development of the kidney. So what are the two parts from which the kidney is derived? So the definitive human kidney is derived from two important things. One is, the keyword is metanephros. Okay. We all know that there are pronephros, mesonephros, and there is a metanephric mass. Okay, there are three things like this. But this metanephric mass it gives rise to the definitive kidney. So we also call it as a metanephric blastema, derived from the intermediate mesoderm. And there is one more structure, the important part, the collecting duct of the kidney. Okay, we have a collecting duct of the kidney, collecting part of the kidney to be more precise. And this collecting part is precisely developed from the ureteric bud. Okay, so metonephros and ureteric bud. Ureteric bud is a protrusion from the cloaca. So it is a ureteric bud or metanephric diverticulum which is arising from the cloaca. So these two simple things, if you remember, you will get very good marks. So kidney develops from two things. One is metanephros and the other is ureteric bud from cloaca. And the same development is depicted in the pictures. You have to draw them. See this. This is the metanephric mass of mesoderm, and you can see the ureteric bud development. And the ureter is also forming here, and the ureteric bud is giving rise to the renal pelvis, and this renal pelvis again divides into major calyces, and which in turn gives rise to minor calyces. At the same time, the definitive mass of the kidney is also developing from the metanephric blastema. Okay, and this is differentiated into cortex and medulla with the renal sinuses. In between you have renal pyramids or medullary pyramids, and this is how the whole of the system develops. And there is some confusion, like we know definitively we have from the mesoderm we have afferent and efferent arterioles which are forming glomerulus. So I'm discussing the nephron part of the collecting part. So we have a Bowman's capsule, and this Bowman's capsule also develops from the metanephric blastema. From here we have a proximal convoluted tubule. We have a descending limb of loop of Henle, we have ascending limb of loop of Henle, and we have distal convoluted tubule. So all these parts they develop from metanephric blastema. From here the collecting duct, the calyces, the pelvis, the whole part develops from the ureteric bud from the cloaca. There is one more part to the development of kidney. Yes, it develops from the following parts. It differentiates and all. So if you draw this diagram, it's more than enough. But there is one more part to this discussion, that is the ascent of kidney. See, there are two important things in embryology. One is descent of testes, which we'll be discussing in the testicular development, and ascent of kidney. Both the stuffs are important. As we all know, the human kidney is derived from metanephros, but this metanephros lies in the sacral region, as you can see. But kidney is in the lumbar region. So during the subsequent development of the embryo, due to the differential growth of the abdominal wall, the kidney ascends to the lumbar region. Okay, so that's the reason the metanephros, at first it receives its blood supply from the lateral sacral arteries. Okay, because it is in the sacral region. After that, during its ascent, the higher branches of the aorta they supply it. Okay, and later on there is a definitive renal artery arising from the aorta at L2 level. L2 level is the origin. So it goes up, and from the L2 level of the aorta it gets its blood supply. If somehow If there is any issue with the ascent of the kidney, then the patient will develop anomaly in position depending upon which position it is or where it is lying down. And this ascent also has a significance in horseshoe kidney. So I'll be discussing that in the next part. But due to the differential growth of the abdominal wall, the kidneys ascend from sacral region to the lumbar region, changing the blood supply from the sacral arteries to the renal artery from L2 level of the aorta. So that's it. So you know the development of the kidney. Let us quickly jump back to the congenital anomalies of the kidney. So first is agenesis. Both the kidneys are one of the kidney might be absent. Okay, renal agenesis is a common condition. Sometimes there is an underdeveloped kidney. Okay, not complete agenesis but underdevelopment. If there is agenesis of unilateral kidney, the other kidney might undergo hyperplasia to support that. The same thing happens with kidney failure. If one kidney is affected, unilateral kidney, the other kidney undergoes hyperplasia to take over the functions. So this is the first congenital anomaly. Next is hydronephrosis. Any blockage, okay, so leads to distension of the pelvis with the urine because of the obstruction in the urinary passages, and we call it as a hydronephrosis. Next is anomalies in shape, like how they look. See, this is horseshoe shaped kidney. Okay, and because the lower poles of the two kidneys, most common is the lower poles, sometimes even upper poles also may fuse. They may fuse either in the front or behind the aorta. Okay, so one important point is take home for you is the horseshoe kidney. Okay, it never ascends above the level of inferior mesenteric artery. Okay, we have celiac artery, superior mesenteric artery and inferior mesenteric artery, which are the single branches, that they are not pair, which are single outlets from the aorta. So what is your take home is horseshoe kidney will never ascend above the level of the inferior mesenteric artery because it prevents its ascent. Okay, it prevents the ascent of, you can see here, this is the inferior mesenteric artery. So this is vein and this is artery, and you can see the inferior mesenteric artery is preventing the ascent of the what we call the horseshoe shaped kidney. Next is pancake kidneys, like the two kidneys, they fuse like a mass. Okay, so we call it as a pancake kidney. There is a lobulated kidney also. The kidney looks lobulated, but overall it's a normal variety, nothing wrong with that. And similarly, there are other conditions, that is congenital polycystic kidney disease. There are two variants, ADPKD, that is autosomal dominant polycystic kidney disease, or ARPKD, that is autosomal recessive polycystic kidney disease. Why this condition develops? Very important. There are two things during the development, as I already told you. One is metanephros and the other is ureteric bud. Okay, so the one pipe is joining to the other pipe. Okay, so failure of the excretory tubules of the metanephros to establish connection with the collecting tubules of the ureteric bud. So these are excretory tubules of the metanephros and these are the collecting tubules of the ureteric bud. If they fail to fuse together, if they fail to establish a contact with each other, then they lead to formation of cyst-like structures. Okay, they are not fusing, so they form cyst. And what happens? The cyst will press the normal renal tissue which is in adjacent to it, because the metanephric blastoma also forms a kidney substance and we have nephrons. All these nephron excretory tubule structures, they are forming cyst, and the cyst-like structures even the damage the intervening normal renal mass or renal tissue. Okay, so this is congenital polycystic kidney disease and there are two variants for it. One is autosomal dominant seen in elderly, autosomal recessive seen in younger infants. So last, a very important one is the aberrant renal arteries. Okay, usually we have a pair of renal arteries arising from the aorta which supply the kidney. Okay, but if there is a failure of ascent, the arteries might be taking origin. For example, if it is in the sacrum, you still have sacral arteries supplying the kidney because of failure of the ascent of the kidneys. So this is aberrant renal arteries. So we are done with the congenital anomalies of the kidney and the development of the kidney briefly. So in this video, I'll be discussing about the spermatogenesis and spermiogenesis, and I'll add few points on the descent of testes during development of the testes. So when it comes to spermatogenesis versus spermiogenesis, so be careful in the exam whether they are asking about spermatogenesis or spermiogenesis. When I say spermatogenesis, it is a complete process of formation of spermatozoa or sperm. It's a complete process. That means it even includes spermiogenesis. Okay, so the starting from the spermatogonium, the divisions, okay, the first and second meiotic division which occurs, and also the spermiogenesis. Whereas spermiogenesis means it is a process of transformation of, just remember this, it is a process of transformation of a rounded spermatid into a tail-like spermatozoa. We know the structure of the spermatozoa. So this single step is spermiogenesis. So let's see how these two things that take place. Okay, so we'll start with the spermatogenesis, the initial steps. First we have the spermatogonia, or we call it as germ cells. And these germ cells, their nuclear makeup is 44X plus Y because they are male. Okay, we also call them as type A germ cells or type A spermatogonia. Okay, so they divide mitotically. So there is a mitosis which occurs. So they divide mitotically to give rise to more type A spermatogonia, and some of them also gives rise to type B spermatogonia. Okay, so this is the first step. The type A divides again to maintain the population of the germ cells, whereas the type B now enters the process of spermatogenesis. Okay, so during the process of spermatogenesis, they undergo mitosis again, and the next step is they form primary spermatocyte. It's kind of differentiating cell. It's a kind of committed progenitor cell. When you take hematopoiesis, we consider primary spermatocyte as a committed progenitor. It's committed now. Once it enters the stage of primary spermatocyte, it should divide. So now after the primary spermatocyte, we have meiotic divisions. Okay, till now we have mitotic, but now here meiotic divisions they start. So let's look at the meiotic divisions. So this primary spermatocyte undergoes the first meiotic division. Okay, and when I say meiotic division, there is a reduction of the cell number and it forms secondary spermatocyte. So these secondary spermatocyte can be 22 plus X or 22 plus Y. And these each secondary spermatocyte, it divides. Okay, it undergoes the second meiotic division to form spermatids. So there are 4 spermatids coming out of a primary spermatocyte, and these spermatids, they are rounded like structures and they should be converted into a new shape. Okay, the shape of a sperm. So the process by which a spermatid becomes a spermatozoa is known as spermiogenesis. Okay, so all the cellular organelles like Golgi apparatus, the centriole, the mitochondria, all these components that transform so that there is formation of the spermatozoa. So let us see how they transform. So we are entering the step of spermiogenesis. Okay, the diagrams are very important. Let me label them. First is the nucleus. Next we have Golgi complex. Okay. We also have mitochondria. And then there are centrioles. So these are the cellular organelles present inside the spermatid. Now you see, each is taking part in a specific reaction. Okay, so you take Golgi complex. The Golgi complex is transforming into the acrosome of the sperm, which helps in penetration into the ovum. The acrosome, or the acrosome cap of sperm, is derived from Golgi complex. Okay, next is the nucleus. The nucleus is forming the head of the sperm. Okay, so the main component of the head of the sperm is the nucleus. And when you take the neck of the sperm has the centrioles. Okay, so the centrioles, they divide into two parts. Okay, and they give rise to axial filament, which grows out. See, from the centrioles, the axial filament is growing out. So the main centriole remains in the neck, and we have an axial filament, a continuum. Okay, so among the centrioles, one centriole is staying in the neck itself. Okay, and the other centriole is forming the basal body of the spermatozoa. So we have neck and the body. So this basal body is formed by the centriole. Okay, and this part of the basal body is surrounded by the mitochondria. You can see the mitochondria, they are now surrounding the body, and this centriole, it continues to form the tail again, which helps in swimming, but these mitochondria are surrounding the basal body, and most of the cytoplasm is lost. So this mitochondrial sheath, which is present near the tail part, it provides energy so that there is a swimming movements of the sperm, so that it reaches to the site of fertilization. So what is more important, at the time of fertilization, this mitochondrial sheath and tail, they are shed off. Okay, they are shed off. Only this part, the head part, which contains the nucleus, that is 23 plus X or 23 plus Y, it enters into the ovum. So that is the reason each individual only gets mitochondria from the mother. So that is the reason the mitochondrial inherited disorders, we inherit them only from the mother, because the father's spermatozoa is not contributing any mitochondria at the time of formation of the zygote, because this mitochondrial sheath, this basal body, the filament, the tail, everything is shed off. Only what enters is the nucleus part of the spermatozoa. Okay, so this is the steps in spermatogenesis and also spermiogenesis. So we are discussing the testicular descent or descent of the testis. As you know, the kidney should ascend. Similarly, the testis should descend into the scrotal sac, because at the time of development, okay, the testis is in the lumbar region. Okay, and from the lumbar region, the testis should migrate to the scrotal sac. Now let's see what is the time period from which it reaches the site, the inguinal region, the lumbar region, to the scrotal sac. So what is the time period? And also let's see what are the factors which help in the descent of the testis. Okay, so they reach the iliac fossa from the lumbar region at 3rd month. Okay, and they lie at the site of deep inguinal ring up to a 7th month. So this is the deep and this is the superficial inguinal ring. So they lie at deep inguinal ring at 7th month. So they reach iliac fossa by 3rd month. They lie at deep inguinal ring till 7th month. They pass through, okay, during the 7th month, they pass through the inguinal canal and they reach the scrotum by the end of 8th month. Okay, so this is the normal time period. Let me repeat. So at the time of formation, the fetal development, initially it is in the lumbar region. It reaches the iliac fossa by third month. It reaches the what we call the beginning of the inguinal canal, the deep inguinal ring, by seventh month. It passes through. It takes a month to pass through the inguinal canal, and by the end of the eighth month, the testis it reaches the bottom of the scrotal sac. So what are the factors which help in this movement? Okay, one very important thing is similar to the growth of the ascent of the kidney, the differential growth of abdominal wall is an important factor. So what are we discussing here? We are discussing the factors which favor descent of testis, and the first factor is the differential growth of the abdominal wall. Please remember, differential growth of abdominal wall. So what is the second factor? Second factor is formation of inguinal bursa. So what is this bursa? It's formation of the scrotal sac per se. From the abdominal cavity, there is a dilatation happening, a bursa kind of structure, a pouch kind of structure forming at sixth month. Okay, so the various layers of the abdominal wall of each side, they form an outperching towards the scrotum. So we do have a scrotal cavity, but the abdomen is also forming an outperching, and this outperching which helps so that whenever the testis comes, the outperching in the scrotum is ready to accept it. So this is known as inguinal bursa. Okay, and the cavity of this inguinal bursa is developing into inguinal canal. Okay, logic is simple. Just imagine an embryo and an infant. There is an outpoaching from the abdominal wall which is entering into the scrotum, and this is ready by sixth month, and this creates the passage called inguinal canal. So this is one factor, the formation of the inguinal bursa. So we're done with the differential growth of the abdominal wall and also the formation of inguinal bursa by the layers of the abdominal wall along with the formation of inguinal canal. The third important step, see, there is a controversy with this. We call it as gubernaculum. So what is this gubernaculum? It's a band of mesenchyme. If you take testis, the inferior part of the testis has gubernaculum, and this gets attached to the bottom of the scrotal sac. So gubernaculum attaches to two structures. One is the bottom of the scrotal sac, other is the lower part of the testis. So many thought that the gubernaculum which is attached to the bottom of the scrotal sac like this, here, this might be pulling the testis into the scrotal sac. But when they examine the gubernaculum, it does not have any contractile tissue. If it cannot contract, how can it pull it? But they have found out that the gubernaculum, whatever is there, the length is constant. Okay, the length is constant. So if it is attached like this to the scrotal sac, just imagine what happens due to the growth of the body. Okay, body is growing, but the gubernaculum is not lengthening. So that's the reason, because of the relative shortening of the gubernaculum, there is entry of the testis into the scrotal sac. So this is what they say. Okay, so one more important factor when it comes to gubernaculum is it helps in dilating the inguinal bursa. Okay, because it is present, it is dilating the inguinal bursa. And one more thing is, because of its presence, it provides a continuous pathway so that the testis is destined to reach the scrotal sac, and this gubernaculum is guiding it so that it reaches the testicular sac. So this is the third point. So we are done with the differential growth of the abdominal wall, we are done with the inguinal bursa development, and we are done with the gubernaculum. The fourth point is the processus vaginalis. So this processus, it's a diverticulum formed from the peritoneal cavity. Okay, it's a diverticulum formed from the peritoneal cavity. Let me draw this. This is the peritoneum covering, and here is the testis, and this is the gubernaculum, and the layers of the abdominal wall. What are those? Transverse abdominis, internal oblique muscle, external oblique muscle, the skin, everything, they are forming the inguinal bursa like this, so that it forms a scrotal sac. So in the this is the scrotal sac, this is the inguinal bursa, this is the gubernaculum, and this is the inguinal bursa, and we have a peritoneal layer. This peritoneal layer also forms an outpouching, a diverticulum kind of structure. So this is known as processus vaginalis. And what does it do? It actively grows into the mesenchyme of the gubernaculum. Okay, and also the scrotum. As the testis descends, this processus vaginalis, it invaginates from behind. Okay, so as the testis descends, there is a background of the processus vaginalis. After the descent of the testis is completed, the processus vaginalis loses all connection with the peritoneal cavity, and this becomes the tunica vaginalis, the covering of the testis. Okay, tunica vaginalis. The persistence of the processus vaginalis might lead to the development of inguinal hernias. Okay, the persistence might lead to the development of inguinal hernias. Now you know the process of descent. Okay, so there are 4 factors. The 5th factor is, we are done with 4 important anatomical factors, but the 5th is a biochemical factor, that is the hormones. Okay, so the descent of the testis is greatly influenced by the hormones of the pars anterior of hypophysis. So that's the reason the gonadotropin hormone injections are given to encourage descent of testis in cases of undescended testis. If the testis fails to descend, we call it as undescended testis. The other name for undescended testis is cryptorchidism. Okay, so the anomalies of the descent is cryptorchidism. So because of this, the organ may lie in the lumbar region, okay, in the lumbar region, or it may lie at the iliac fossa, or it may lie in the inguinal canal. Okay, so this is undescended testis. But undescended testis, the problem with undescended testis is 2 things. It might lead to infertility, and the undescended testis also has high chances of developing seminoma. Please remember, most of the undescended testis, they immediately descend after birth. Okay, you have to wait in premature infants and all. But if they are not doing within 1 year, you have to immediately operate it, because they have high chances of developing infertility in later part of life, because of the maybe the temperature variation. We all know that the scrotal sac is 1 or 2 degrees centigrade less body temperature than the overall body. So infertility might develop, and also seminoma, that is undescended testis has more chances of developing malignant tumor than a normal testis. Okay, and we do orchidopexy to correct it. What we call it, the surgery is orchidopexy, which helps in correcting the cryptorchidism. So what we are done? We are done with the normal testicular descent, the time period, the factors which are affecting the testicular descent, and what happens if the descent fails. Okay, so there is one clinical condition called ectopic testis, and you need to know the difference between ectopic testis and undescended testis. Okay, it is staying in the lumbar region, it is staying at the iliac fossa, it is in the inguinal canal, fine. This is a normal path. What if you find testis under the lower skin of the abdomen, lower part of the abdomen, under the skin, or if you are seeing it in the front of the thigh, or if it is in the femoral canal, or if it is in the underside of the skin of the penis, or if it is in the perineal part. So these are not usual locations, and we call these as the ectopic positions of the testis, and this might develop due to abnormal pulling of the gubernaculum into the various locations which are not a normal part of the descent. So this will conclude the difference between ectopic testis from undescended testis, and you know the locations for both undescended testis and ectopic testis. Hi, hello doctors. So let us look at the histology of testis now. It's a very important topic. So here in the image you can clearly see testis is covered by a double layered sac, and the name of this double layered sac is tunica vaginalis. Okay, so the 2 layers are, one is parietal layer and the other is visceral layer, but you can clearly see some part of testis is actually devoid of this tunica vaginalis. Okay, so this part which is actually not covered by the tunica vaginalis is mediastinum testis. Okay, so I'll tell you what is mediastinum testis, but before that, beneath the tunica vaginalis, we have a thick fibrous membrane which is actually covering the substance of the testis, and this thick fibrous membrane is tunica albuginea. So what is this? Tunica albuginea. This tunica albuginea, it extends throughout the testis, but in the posterior wall of the testis, it condenses to form a thick band. Okay, and this thick band which is present on the posterior wall of the testis is actually known as the mediastinum testis. See this has condensed here, and this is mediastinum testis. From the mediastinum testis, fibrous septa, they spread across the substance of the testis, dividing each testis into approximately 20 to 30 lobules. Okay, so the fourth structure is each testis has 20 to 30 lobules, and inside each lobule approximately 1 to 3 convoluted tubules are present, and these tubules which are actually present, see here, there is a convoluted tubules here. So these tubules are seminiferous tubules. These are the primary structures which actually are important structures for spermatogenesis. Okay, the sperms are generated inside these seminiferous tubules, and they are present inside the lobules, and this lobular separation is by mediastinum testis. When you look at a seminiferous tubule, it is a loop-like structure. Okay, so you can see it loops like this. So each seminiferous tubule, at the end, each loop unites to form a single duct. Okay, and all the seminiferous tubules, okay, they unite with each other. All the seminiferous tubules, they unite with each other, and they form approximately 20 to 30 straight ducts. Okay, so straight ducts or ductule is the peripheral structure of seminiferous tubules. All these straight ductules, they convolute. Okay, they form a mesh-like structure at the mediastinum. So at the mediastinum testis, these are all straight ductules. You can see they unite in the substance of the mediastinum to form another structure called rete testis. So we have rete testis which is formed from the straight ducts. After this, the rete testis at the terminal end gives rise to efferent ductule. Okay, so efferent ductules, what is the number of the efferent ductules? They are 12 to 20 efferent ductules which are derived from rete testis. So rete testis gives rise to efferent ductules. The efferent ductules, you can see they again convolute. Okay, they again convolute, and these convolutions, they form head of the epididymis. Head of epididymis. Now tell me, the head of epididymis is formed by efferent ductules which are derived from rete testis. And what are the other two parts of epididymis? One is head, the remaining two are body and tail of the epididymis. Okay, so these efferent ductules, okay, these efferent ductules, they join together to form a single duct. Okay, they join together to form a single duct, and this is known as duct of epididymis. All the efferent ductules 12 to 20, they unite to form a single duct known as duct of epididymis. So after the unity, this duct of epididymis, it again convolutes. Okay, it again convolutes, and this convolution forms body and tail of the epididymis. So the body and tail of the epididymis are formed by the convolutions of the duct of epididymis. You can see the convoluted duct of epididymis is forming the body and tail. See what happens at the terminal end of the tail, these convolutions, they straighten up and they open into the final structure called ductus deferens. What is the other name for ductus deferens? It is vas deferens. So from the vas deferens, along with the seminal vesicles, it opens into urethra and the sperm comes out, right? Let me quickly summarize this. Starting with tunica vaginalis, then we have tunica albuginea. See, first is tunica vaginalis, followed by tunica albuginea, a thick fibrous substance which is made up of collagen and elastin. And posterior part of the posterior wall of the testis, which is formed by tunica albuginea, is mediastinum testis. This separates the testis into lobules, and these lobules contain seminiferous tubules, and seminiferous tubules unite to form, what is this? Straight ductules, and the straight ductules unite at the mediastinum of the testis to form rete testis. This is rete testis, and the rete testis gives rise to efferent ductules. Efferent ductules convolute to form head of the epididymis. Efferent ductules give away the duct of epididymis. The duct of epididymis convolutes to form body and tail. At the terminal end, the duct of epididymis unites with the vas deferens or ductus deferens. So this is the normal histology of the testis. There is one more point to be added here. Within the substance of the seminiferous tubules, there are interstitial cells. Okay, so the other name for these cells is interstitial cells of Leydig or Leydig cells. What do? They secrete testosterone. The male sex hormone is secreted by these Leydig cells. Hello students, let's start discussing about the development of uterus. Okay, followed by the developmental anomalies. So uterus develops from paramesonephric duct, right? The paramesonephric duct arises from lateralmost part of nephrogenic cord, right? So you know, right, where is the nephrogenic cord? So this will be the nephrogenic cord, and this is the dorsal mesentery, and from this the lateralmost part gives rise to the paramesonephric duct. Medial to it we have a mesonephric duct, also known as Wolffian duct, and paramesonephric duct is also known as Mullerian duct. The paramesonephric duct, after its origin, it crosses the mesonephric duct, and in the middle it fuses, right? So I'll call it as Mullerian duct from now onward. So there is a duct formation and its fusion. Okay, the fused Mullerian ducts, they form uterovaginal canal. So this is the uterovaginal canal. Over it, the mesoderm which present condenses to form the myometrium of the uterus. So this is how uterus forms. The unfused portions of the paramesonephric ducts, they form fallopian tubes. So after the fusion, usually there is a septal resorption, so that we get a fundus and the cavity of the uterus. If there is any defect either in the fusion or the septal resorption, these things, they lead to congenital Mullerian malformations. So the American Fertility Society has given a classification system in which we have 6 classes, right? The class 1, you see agenesis. Class 2 is unicornuate uterus. Class 3 is uterus diadelphys. Class 4 is bicornuate uterus. Class 5 is septate uterus, and class 6 is arcuate uterus. Let's have a quick look into the different malformations associated with formation of uterus. Okay, so here the first is, let us start with the agenesis part. Okay, it is not mentioned here. Agenesis means complete absence of the uterus. So what is the other name for this? There is a syndrome. Okay, Meyer, Rokitansky, Kushner and Hausner syndrome, that is MRKH syndrome. In this you will have complete absence of the uterus. That okay, and the next is we'll start with septate uterus. Okay, what is septate uterus? In the septate uterus, you will see, yes, both the paramesonephric ducts, they fuse together. Okay, but the fusion, the partition, whatever is there, it remains. Okay, there is no disappearance of this partition. So this is septate uterus, and the importance of septate uterus is it is the most common uterine anomaly. Okay, most common uterine anomaly which leads to miscarriages. Okay, which leads to miscarriages. And next one is arcuate uterus. In arcuate uterus, there is an image here, you can see. There is an indentation at the fundus part, slight indentation, which is indenting into the fundus. So this is just uterus arcuatus, and there is nothing much clinical importance for this variety. Okay, just indentation of the fundus slightly. Okay, so this is uterus arcuatus. And the fourth variety is uterus unicollis. Okay, or unicollis or unicornis. In uterus unicornis, what happens is, one side of the paranephric duct it develops, and the other side there is improper or non-development of the other side of the paranephric duct. So only one duct remains and it forms the structures. So this gives banana shape. Okay, so the banana shaped uterus is seen in uterus unicornis. Okay, uterus unicornis, the banana shaped uterus. Next is, we're done with 1, 2, 3 and uterus unicornis. The fifth variety is, we'll start with uterus diadelphys. Okay, uterus diadelphys, the other name is double uterus. What happens in this? There is failure of fusion of the paramesonephric or Mullerian ducts. So when they fail to fuse, two separate uterus forms. Okay, sometimes even the vagina is also double. Okay, here the vagina is double, but this is not always correct. Sometimes there is a single vagina and few times you see a double vagina here. So this is uterus diadelphys or double uterus. The sixth variety is uterus bicornis. Okay, so uterus bicornis. Uterus bicornis and septate uterus, they all look similar. Okay, so diadelphys is non-fusion, septate uterus is complete fusion, but the fused part failed to disappear. Okay, failed to disintegrate. Uterus bicornis comes in between. Okay, the fusion starts, but some part of the fusion remains and some part of the fusion disappears. So this leads to indentation on the fundus, leading to fundal cleft. Okay, fundal cleft. So there is some part of disappearance and some part is persistent. So please, when I say uterus bicornis, just remember this key word called fundal cleft. And in MRI, usually the most sensitive investigation to look at uterine anomalies is definitely the MRI of the pelvis, right? So here in MRI we look at the fundal cleft, and if the fundal cleft is more than 1 centimeter, we categorize this abnormality as uterus bicornis. If it is less than 1 centimeters, we call it as septate uterus. I'll repeat this again. In an MRI, if the fundal cleft is more than 1 centimeter, we call it as uterus bicornis, because cleft is forming because of the disintegration. In septate uterus, there is no disintegration or disappearance of the septum. So this will help you in differentiating septate uterus and also the uterine bicornis. This uterus bicornis is again divided into unicollis and bicollis. Okay. So what is this differentiation? Bicornuate uterus with a division above the os, that is external os, is known as unicollis variety, and the bicornuate uterus with division up to os or below the os is known as bicollis variety. Okay, so we covered agenesis, septate uterus, arcuate uterus, unicornuate uterus, bicornuate uterus, and also the uterus diadelphys. So there is another variety of uterus called T-shaped uterus. So this T-shaped uterus is seen if the baby during the development is exposed to diethyl stelbestrol. So DES exposure leads to T-shaped uterus. There is another important shape called heart-shaped uterus. And where do we see this heart-shaped uterus? Heart-shaped uterus is actually the bicornuate uterus. Because of the two limbs, they look like aorta and pulmonary artery. So it is bicornuate uterus gives rise to heart-shaped. So before concluding, there is one more uterine abnormality called rudimentary horn. See, there is a separate horn with unicornuate uterus. And what is this? This is a separate development. Okay, so there's no fusion between this duct. This is a rudimentary horn. Now let us try to understand the embryology of urogenital system. Okay, this topic is very important, and first point which is very important is the urogenital system is derived from two important components. Okay, first is the intermediate mesoderm and the second is cloaca. Okay, so these two are the parent embryonic structures which give rise to urogenital system. Intermediate mesoderm is located in between the lateral plate mesoderm and paraxial mesoderm. Okay, so in between lateral plate and paraxial mesoderm we have an intermediate mesoderm, and from the intermediate mesoderm, okay, there is a structure known as nephrogenic cord. Okay, and if this is the primary, this is the secondary parent for the formation of urogenital system. To understand this, as we all know, the embryo, when it folds on itself, it develops few cavities, right? It forms pericardial cavity, it forms pleural cavity, and it also forms peritoneal cavity. Okay, this is the ventral part of the embryo and this is the dorsal part of the embryo. The dorsal side, we have the intermediate mesoderm spreading as a cervical, thoracolumbar and the sacral areas. We have this intermediate mesoderm. Let me show it in a cross section. Okay, so this is the dorsal wall, that is the posterior skin, and we have a dorsal mesentery which is actually attaching the intestine here. Okay, so this is dorsal mesentery, and on both sides of the attachment of the dorsal mesentery on the dorsal part we have nephrogenic cord. Okay, so nephrogenic cords are bulge-like arrangements which are present on the posterior wall of the body. Okay, the dorsal part, they are lateral to the dorsal mesentery, okay, which is attaching the intestine. And this nephrogenic cord, if I zoom it, so this is the nephrogenic, single nephrogenic cord. In this we have structures which are developing. Okay, so this lateral most structure is paramesonephric duct. So what is this? This is paramesonephric duct, and slightly medial to it there is another duct which is mesonephric duct. Okay, which is mesonephric duct. And we also have these excretory tubules are mesonephros which are present medial to the mesonephric duct, and most medial structure which is actually derived from, what is this layer? This is nephrogenic cord, but this nephrogenic cord is covered by a layer which is actually covering the peritoneal cavity. The layer which is actually covering the peritoneal cavity is coelomic epithelium. So this is important because from the coelomic epithelium, the medialmost part of the nephrogenic cord and the coelomic epithelium, they give rise to gonads. Okay, so these are the four important structures which are derived from the nephrogenic cord. And you know where this nephrogenic cord is present. It is present on the dorsal wall. It is a continuous structure extending from the sacrum, okay, to extending from the cervical part to the sacral part of the body. So this is the nephrogenic cord, and the mesonephric duct, paramesonephric duct and gonads, they develop from the nephrogenic cord. All these structures gives rise to few important parts of the urogenital system. Let us look into the table now. So here if you see the embryonic structure, labioscrotal squelling. Okay, so these are not important. Urogenital folds is also not important. Genital tubercle, okay, but start with urogenital sinus. Okay, so as I told you, the first important structure is nephrogenic cord or intermediate mesoderm, right? The second structure is cloaca. Let us look at the development of the cloaca. Okay, so what happens here, the cloaca itself is subdivided into two parts, that is primitive urogenital sinus and the rectum part. So now this primitive urogenital sinus, okay, this has if this is allantois, right? Allantois is followed by cloaca, and you know now cloaca is divided into two parts. One is the primitive urogenital sinus, which I am drawing now, and the other is the rectum, right? This part is rectum. So this primitive part is again subdivided into two parts. The cranial most part, this is allantois. The cranial most part is vesico-urethral canal, okay, and the caudal part is definitive urogenital sinus, okay. So total is primitive, but after giving away the vesico-urethral canal, this is the definitive urogenital sinus. This urogenital sinus during further development is again divided into like two more parts. One is the pelvic part, which is cranial. This is the pelvic part, and the other is the phallic part, which is caudal. So this is the division of cloaca, which is the second important structure in formation of urogenital system. Now you see, we'll start with the embryonic structure and the male and female derivatives, okay. So first three are not so important, but starting with the urogenital sinus, what are all the structures which are derived from urogenital sinus? Okay, urinary bladder, urethra, prostate gland, prostatic utricle, and bulbourethral glands in males. Similarly, urinary bladder and urethra, urethral and paraurethral glands, but very important is vagina is derived from the urogenital sinus and Bartholin's glands, okay. So one take home for you is vagina is derived from urogenital sinus, Bartholin glands from urogenital sinus, urinary bladder in both male and female from urogenital sinus, right? Next important structure for exam point of view is paramesonephric duct. The other name for paramesonephric duct is Mullerian duct, right? Paramesonephric duct, which is lateral most part of the nephrogenic cord, it gives rise to important structures in females, okay. Para, gravida, these are the terms which we use for females, right? While we are writing down the obstetric formula. So you have to remember para means predominantly females. So what are all the female structures which are derived from paramesonephric duct? One is hydatid of Mogagni, okay. Other is uterus, cervix, fallopian tubes, and some part of the vagina is also derived from the paramesonephric duct. Paramesonephric duct is a vestigial remnant when it comes to males. So it is vestigial in males. The only structure which is present from the paramesonephric duct, and which is a important question, is appendix of testis, okay. So the appendix of testis is a derivative of paramesonephric duct in males. Next is the mesonephric duct, the counterpart. We already discussed the paramesonephric. Paramesonephric means predominantly female. Mesonephric is predominantly male, okay. So the male part of the genital system predominantly is derived from the mesonephric, right? So what are the structures? Ductus epidermis, ductus deferens, and seminal vesicles. So these are all derived from the Wolffian duct. When it comes to females, the female has Gartner's duct, okay, and also the duct of Epophron, okay. So these are the two structures which are derived from the mesonephric duct, okay. So what is mesonephric tubules then? We all know during the development of the kidney, the intermediate mesoderm has structures. One is pronephros, other is mesonephros, and the last is metanephros. The metanephros develops into metanephric blastema, okay, and it does not have any duct, metanephric blastema, and this metanephric blastema is the future kidney, right? But for the kidney, the pelvis, the ureter comes from the extension of mesonephric duct. So this is the ureter duct, okay. So this is how ureter bud comes, and it forms ureter from the mesonephric duct. So pronephros, it disintegrates. Mesonephros remains as mesonephric duct, okay, but the substance of mesonephros has some tubules, okay. So these tubules, most of them degenerate. So mesonephric tubules, let me put it this way. Pronephros includes both duct and tubules or ductules. They both degenerate. Mesonephros has both duct and tubules. The ductular part remains and it forms important structures as we discussed. The same mesonephric duct gives ureter also. Okay, whereas metanephros only forms tubules, that is the major part of the kidney. It doesn't have any duct. So the duct, that is the ureter, is actually coming from the mesonephric duct. So these tubules, when we come to mesonephric tubule part, the tubules, most of them degenerate, but some remains, and they help in actually formation of the male genital system, that is the gonadal part. See this? The ductulo efferents and paradidymus are actually derivative of mesonephric tubules. Some tubules, they remain in females as vestigial structures, and these mesonephric tubular remnants in females is known as epiphron and paraophron. So very important. So epiphron and paraophron are derivative of mesonephric tubules. Duct of epiphron and Gartner's duct are derivatives of Wolffian duct or mesonephric duct. So this duct and tubule differentiation is very important. So ducts versus tubules. Next is, yes, the gonads, cortex and medulla, they give rise to testis, seminiferous tubules, rete testis, ovary, ovarian follicles, rete ovary and all, gubernaculum, Mullerian tubule. All these are not important. So the only few things that you should keep in mind is mesonephric tubules, mesonephric duct, paramesonephric duct, and the urogenital sinus. So let us discuss one of the important and complex topic, that is the development of heart. So I'll be discussing the development of heart along with the congenital anomalies associated with development of the heart, and I'll also be adding a note on the anatomy of the right atrium of the heart. So these are the three topics I'm going to cover in this video. So to begin with, as I already told you, the development of heart is a complex process. So to avoid confusion, okay, I'm only giving you the main facts which are important for the exam. Okay, so heart develops from, the first and foremost key point or key word you should understand is that heart develops from an angioblastic tissue, and this angioblastic tissue is derived from, very important, it is derived from, you just remember, LPM, that is lateral plate mesoderm. Okay, and this lateral plate mesoderm has two structures. Okay, one is the splanchnoparietal epithelium, the other is splanchnopluric epithelium. So out of the two different epithelia, it is the midline splanchnopluric coelomic epithelium that gives rise to the angioblastic tissue, which in turn gives rise to the heart. So that's it. So the heart develops from the angioblastic tissue derived from midline splanchnopluric coelomic epithelium of lateral plate mesoderm. What it is, where it is, it's not important, but just try to remember this LPM. So as I already told you, let us only discuss the main events in the development of the heart. Okay, and the first and foremost thing to develop is the development of the heart tube. Okay, so there is a heart tube, and later on there is the growth of this tube and folding, giving rise to the atria and ventricles, but they should be partitioned. So there is a partition, so later on there is development of the sinus venosus and it's merging into the right atrium, and there are also the venous development of the left atrium, and at the end there is development of the ventricles. So the first part is the development of the heart tube. The heart is mesodermal in origin. It arises from the cardiogenic area. The heart first is seen in the form of two heart tubes. So number 1 and number 2. There are two heart tubes or endothelial heart tubes. One is right and the other is left. Okay. So in this, whenever there is a formation of the heart tube, later on they fuse together. What happens to them? They fuse together to form a single heart tube, and this single heart tube later on shows some dilatations. Okay, it dilates, producing 4 important areas. Okay, so what are the 4 important areas in cardiac dilatation? First is the bulbus cordis, and this bulbus cordis is close to the development of the arterial arches. Okay, so the arterial system is here and the bulbus cordis is close to the arterial development. The opposite counterpart is sinus venosus, which is a fork-like structure. Okay, there are two things here, two arms here. Okay, not arms, we call them as horns. We have a right horn and the left horn. Okay, so this sinus venosus is in continuum with the venous system. Okay, from the periphery of the body, the venous opens into the sinus venous. So venous system empties into the atria. We all know that. So this is the primitive atrium. Okay, the primitive atrium receives the venous entry, and the arterial blood flows into the ventricles. Okay, so this is exits from the ventricles. So this part is the ventricle part, and we call it as a primitive ventricle, and this is primitive atria. Done. So what is the first step? First, the development of heart starts in third week with the appearance of two heart tubes which fuse together to form a single heart tube, and this single heart tube develops dilatations, and the four dilatations, the series of dilatations are bulbus cordis, primitive ventricle, primitive atrium, and sinus venosus. The atria and ventricles are connected by an atrioventricle canal. Okay, so this is the atrioventricle canal. So let's step into the next step, that is the growth and folding of the heart tube. So there are four initial serial dilatations, but this has a further folding. Okay, as we all know, the heart is covered by the pericardium. So if this is the pericardium and if this is the heart tube, what we are seeing here, the problem here is the heart grows, but the pericardium is more or less static structure. So if the pericardium doesn't grow, the heart bends on itself, okay, so that the length can be occupied by whatever pericardial cavity we have. So whenever there is a differential growth in comparison with the pericardium, the heart tube folds on itself to attain a modern shape. Okay, so this point is very important. So this cardiac looping or bending, it starts at day 23, okay, and it is completed at day 28. We all know the events of the heart development are starting at third week of gestation, okay, and from day 23 to 28 you will see a cardiac looping or bending. So when I say cardiac looping or bending, let us look at the parts here. So as you have a preliminary idea that this is bulbus cordis, the bulbus cordis is again divided into the following structures. Okay, so let us look at the main divisions or subdivisions of the heart tube and their fate. That is, what are the structures which they are giving rise to. So this part is very important. We are discussing the subdivisions of the heart tube and their fate. To begin with, we have bulbus cordis. It is divided into three segments. We have a distal 1/3 of the bulbus cordis, and we have middle 1/3 of the bulbus cordis, and next we have the proximal 1/3 of the bulbus cordis. Each third has its own name. So let us start with the distal 1/3. The distal 1/3 is known as truncus arteriosus. What is this? It is truncus arteriosus. And what are the structures it gives rise to? It forms ascending aorta and pulmonary trunk. So what is it forming? It is forming ascending aorta and pulmonary trunk. Simple. And next structure is the middle 1/3, and middle 1/3 gives rise to, we call it as conus, the conus of bulbus cordis, and this conus gives rise to outflow tracts. Okay, it helps in formation of outflow tracts for the right and left ventricle, because this is the primitive ventricular part. And next, the proximal 1/3 part, it has no separate name. Okay, so it forms a kind of trabeculations and it merges with the ventricular part. Okay, so it merges and it helps in formation of the primitive ventricle. So whatever ventricle which is remained, it merges and it forms a primitive ventricle. Then between this bulbus cordis and the ventricle, this line of separation is known as bulbocerebellar bulboventricular sulcus. So what is this line of fusion? It is bulboventricular sulcus. Okay, so this let me clarify this. The proximal 1/3 part helps in formation of the primitive right ventricle, whereas the primitive ventricle, what I am discussing here, this part, the ventricular part, it forms mainly the primitive left ventricle. Okay, so these are the two important structures. So beneath this we have, so this is bulboventricular sulcus, and beneath this we have atrioventricular canal. So it is a separating part between the atria and ventricles, and we call it as a atrioventricular canal. And then we have atrium. So when you look at the atrium, okay, this primitive atrium is partitioned to form the right and the left atria. Okay, it gets partitioned to form right and left, but the primitive ventricle do not get partitioned. The conus, the what we call it as the proximal 1/3 part and the primitive ventricle part, both together form the right ventricle and left ventricle, the primitive parts, relative, what we call it as first the upper part forms right ventricle, then the lower part forms the left ventricle. But that is not the case with the atria. The primitive atria itself separates to form the right atria and the left atria. Okay, so beneath this right and left atria, so we have a separation between what is the structure? This is sinus venosus. Okay, we have sinus venosus, and as I already told you, it has two horns. One is right horn and the other is left horn. Okay, and this is the body of the sinus venosus, right and left horns, and these right and left horns, they have let me draw it this way. We have three veins in each horn. Okay, we have three veins in each horn. So this left side, we are starting with the left side. We have left common cardinal vein. You have to remember this, there is no alternative. Left common cardinal vein, and we also have left umbilical vein, and we also have left vitelline vein. So what are the three important veins that opens into the left horn of the sinus venosus? It's common cardinal vein, umbilical vein, and vitelline vein. The same thing is on the right side. You have right common cardinal vein, right umbilical vein, and right vitelline vein. Okay, let's see what structures these things they form. Okay, if you take body, the body of the sinus venosus, it is absorbed into the smooth right atrium. So the body gets absorbed into the right atrium, and it helps in formation of the smooth part of the right atrium. So right atrium, the sinus venosus gets absorbed into the right atrium. And next we have horns. Okay, the left horn and the right horn. Just look at the fate of the left horn. The left horn of sinus venosus, it undergoes retrogression. Okay, retrogression or regression. So whatever part which is remnant or which remains, it forms a part of coronary sinus. Okay, if you want to remember, well and good, or else just remember that the left horn of the sinus venosus, it regresses or retrogresses. You go back to the right horn of the sinus venosus. The right horn of the sinus venosus, it again gets converted into the right horn of the sinus venosus. It gets again absorbed into the right atrium. Okay, so you can just see, along with the primitive atria, the right atrium is also getting absorbed. It is also getting help from the body of the sinus venosus and also the right horn of the sinus venosus. That is the reason the examiner is more interested in asking about the development of the right atrium. So yes, we are discussing the fate of the sinus venosus. The body is absorbed into the right atrium. Along with that, the right horn is also absorbed into the right atrium. The left horn and the veins here, they retrogress. Some part of the coronary sinus they form, but look at the right veins. As I already told you, we have three things. One is vitelline vein, other is umbilical vein, and other is common cardinal vein. The right common cardinal vein, because it is on the right side, the right common cardinal vein, it forms a part of superior vena cava. Okay, and right umbilical vein, it disappears, and the right vitelline vein, it forms a part of inferior vena cava. Okay, just imagine the heart. Now you will get a clear idea. As I told you, the heart, there will be a cardiac looping or bending, and we have the left ventricle, right atrium, left atrium. Okay, and we also have the interventricular interatrial septums and also the atrioventricular septums. Now you see here, in the right atrium, we have both openings of superior vena cava and inferior vena cava. Why they are there? You can clearly understand. The right horn of the right sinus venosus is getting absorbed into the right atrium along with the body, and the right common cardial vein is giving to a part of superior vena cava, and right vitelline vein is giving a part of inferior vena cava, and they're both going and absorbing into the right atrium. Simple. It's as simple as that. Next, we are done with the fate of, that is the heart tube, its growth and folding. Now let us look at the individual development. Okay, so the next is how the right atrial septum forms. Okay, interatrial septum, sorry. So why this interatrial septum formation is important clinically? Because we have a condition called atrial septal defect, and what happens in that condition of ASD, it is because of the patent foramen ovale. So that means if this interatrial septum, so what you are seeing here is two things. This is the right atria and this is the left atria, and we have interatrial septum formation. If this formation doesn't occur properly, then there are high chances of developing the patent foramen ovale. So let's look at the formation of interatrial septum. Then it is followed by the formation of the interventricular septum. Okay, so in interatrial septum, before directly going into the understanding the interatrial septum, just look at this diagram again. You can notice one interesting thing here. This part, what you're seeing here in between the atria and what we have, the sinus venosus, atria and the sinus venosus, we have an area, okay, we have an area, sinoatrial orifice. What is this? Sinoatrial orifice between the sinus venosus and the atria. We call it as a sinoatrial orifice. The same sinoatrial orifice, I am drawing it in a different section. Just focus here. We have the atrium, and in the atrium we have a sinoatrial orifice, and from here if you look down, you have a sinus venosus below. This is sinoatrial orifice. During the development, what happens, this whatever sinoatrial orifice is seen, it moves to the right side of the heart, okay, into the right atrium, and it also becomes, yes, it is moving to the right side, and instead of being circular, it is becoming, okay, it is becoming vertical. Logic is simple. The same circular opening between the atria and the sinus venosus is becoming narrow and vertical and moving to the right side. So this part now we call it as, this area is now where it is attached to the right atrium, we call it as septum spurium. Okay, there are more septum names coming, so that's the reason you need to focus. This is septum spurium, and this septum spurium has two venous walls. We have left venous wall and we have right venous wall. Okay, we have left venous wall and right venous wall. So what I am telling you, I am telling you the same thing what you are seeing here. In the right side of the heart, in the right atrium, we have the sinoatrial orifice. Okay, the sinoatrial orifice, and this sinoatrial orifice has a septum spurium. and also it has the right venous wall and the left venous wall. Okay, done. So with this basic knowledge, let us quickly jump into the development of the interatrial septum. Exactly to the left side of the whatever structure, the sinoatrial orifice, okay, from the roof of the atrium to the left of the septum spurium, there is a structure called septum primum. Let me repeat it. From the roof of the atria, left side of the septum spurium, we have septum primum, which is growing. So it grows downwards and it grows towards the atrioventricular. Okay, it grows towards the atrioventricular canal, and it ultimately fuses with the septum intermedium. So what does it do? It fuses with the septum intermedium. And next step in the development is, at the time of its fusion in between the septum primum and also the septum spurium, there is a development of one more structure. What was that? It is septum secundum. Okay, it is septum secundum. So this is the AV cushion, and this union is called as septum intermedium. As I told you, septum primum grows towards the AV cushions and it fuses with septum intermedium. But we all know that during the fetal period, the blood should always pass from to the right to the left ventricle to support the growth of the fetus. To allow that, what happens? Before the septum primum fuses with septum intermedium, there is an opening called foramen primum. The first opening is foramen primum. It's like a temporary opening. This will not stop here. The septum primum, it starts growing towards the septum intermedium, and one day it fuses with it. When it fuses, the blood supply from right to left should continue always. So for that reason, there is some regression of the septum primum in the top area, okay, near the roof. So this regression, this disappearance of a part of the septum primum to allow the passage of the blood, there is a formation of the foramen, and this foramen is called foramen secundum. Okay, at the same time, there is growth of this septum secundum to the right of the septum primum, to the left of the septum spurium. And when it starts growing, it reaches the upper free edge of the septum primum. Okay, it reaches the upper free. Now the blood should pass through the tiny opening present here in between the septum primum and septum secundum, and this opening is known as foramen ovale. Okay, don't confuse. I'll just brief it once again. See, we need interatrial septum, but the importance of interatrial septum is there should be a foramen which should be present throughout the fetal life, so that the blood from the right side of the heart should go to the left side of the heart. So initially we have two things. One is septum spurium and the other is septum primum. So this septum primum grows towards septum intermedium. When it is growing towards the septum intermedium, initial time we have a foramen primum which is always present to allow the passage. But one day the septum primum fuses with the septum intermedium, and to allow the passage of the blood, there should be an artificial creation of one more foramen, and this foramen is known as foramen secundum. When there is a foramen secundum, parallelly there is development of septum secundum, and this septum secundum grows towards the septum primum, and the gap persists between the septum secundum and septum primum, and this gap is known as foramen ovale. What happens immediately after the birth? The left pulmonary veins, they open, so there is a blood coming from here, the pressure increases, and this will push the septum secundum tip towards septum primum tip towards the septum secundum. They fuse together and they form fossa ovalis, and if this fails, the patient will have the patent foramen ovale, and this condition is known as ASD, that is atrial septal defect. So we are done with the partitioning of the developing heart, and in that we have discussed the partition of the interatrial septum. There is a partition which needs to occur between the atria and the ventricles, right? So this partition is also important. This develops with the help of formation of AV cushions. So there is a development of atrioventricular cushions. At first, you look at the atria and the ventricles, there is a circular AV canal. Okay, and from this circular AV canal, two cushions develop. One is the dorsal and other is the ventral cushion. So these dorsal and ventral cushions, they fuse in the middle. They fuse in the middle to form atrioventricular cushions, and they form septum intermedium. So this is how AV cushions or atrioventricular septum develops, and you already know how interatrial septum develops. Let us look at the formation of interventricular septum. So we are discussing the development of partitions of the heart. So we are looking at the formation of interventricular septum. So to understand the formation of interventricular septum, you need to have a clear idea of the development of the ventricles. Okay, as I told you, we have four dilations, right? We are done with the venous cyanosis and the primitive atria. They fuse together to form the right atrium and the atrial structures. Similarly, we have the primitive ventricle with the bulbus cordis. Okay, what was that? The bulbus cordis has three parts. Upper one is truncus arteriosus, okay, and middle one is conus and conus cordis, and we have a lower part. And what does that lower part gives rise to? It forms trabecular part of primitive right ventricle, and the trabecular part of primitive left ventricle is formed by our ventricular proper. Okay, so we have the proximal 1/3 part, we have conus. So this conus, the proximal 1/3 of the bulbus cordis and the primitive ventricle, they all give rise to the formation of the ventricle. So the same thing is depicted here in this image. Okay, there is formation of the AV cushions which are forming an atrioventricular septum. Okay, we all know that atria come in front during the development and ventricles they mainly goes back. And we also have an outflow tracts here, see, and these outflow tracts, they give rise to the pulmonary trunk and aorta. Okay, pulmonary trunk and aorta outflow tracts, they are formed from the truncus arteriosus, that is the distal 1/3 of the bulbus cordis. We have middle 1/3 of the bulbus cordis, that is conus, and this conus is forming the outflow tract for both the right and the left ventricles. And now we have the right ventricle and left ventricle. As I told you, the trabeculated part of right ventricle is formed by the proximal 1/3 of the bulbus cordis, and the trabeculated part of left ventricle is formed by the ventricular proper, and this occurs because of the folding. That's it. So this is how the ventricles are formed. Next important step is there are formation of two septums. One is from the floor of the ventricle, there is development of interventricular septum. Okay, the first one is from the floor there is development of interventricular septum, and from the top there is development of bulbar septum. Okay, so two ridges, the bulbar ridges, arise in the wall of the bulboventricular cavity. They grow towards each other and fuse to form bulbar septum, and this bulbar septum grows downwards and towards the interventricular septum. But this bulbar septum and interventricular septum, they do not fuse with each other. The gap which is left is actually filled by the atrioventricular cushions, which are actually forming the atrioventricular septum. So that's it. We are done with the second part, and also the development of the ventricles and also the development of the right atrium. Okay, so partitioning of the developing heart is done. Now the sinus venosus and its derivatives and development of right atrium, we already discussed it, but just I'll explain the image here. Okay, as I already told you, the most important part to be known here is the left part of the sinus venosus disappears, but the right part of the sinus venosus, we have right vitelline vein. Okay, and we also have the right common cardinal vein. Okay, and some part of the left vein it remains forming coronary sinus. Right umbilical vein disappears. Okay, they fuse into the wall, so they're fusing with the right atrium. So the sinus venosus is getting absorbed into the right atrium, and this gives rise to inferior vena cava, and this gives rise to the superior vena cava opening, and this is a coronary sinus opening. Okay, this is a coronary sinus opening and it comes from the left part of the heart, and this is the wall of the right atrium. So the same thing is the sinus venosus takes part in the development of the right atrium. Development of left atrium is pretty simple. Okay, the left half of primitive atrial chamber, it dilates, okay, and it forms the left atrium, okay, and it communicates the part of left atrium. It tries to communicate with the truncus arteriosus, and there will be opening of the pulmonary veins into the left atrium. So left atrial development is not important for our discussion. And yes, that is what I am telling you. The development of left atrium is pretty simple. The development of ventricles is already done. So now I think you have a clear idea about the development of the atria and ventricles, the development of the partitions between them. Let us quickly jump into, with this background knowledge, let us quickly jump into the congenital anomalies of heart. So there are many things that needs to be discussed when it comes to congenital anomalies of heart. So the list is exhaustive. So what I'm trying to do is I'm trying to cover these 9 important congenital anomalies of the heart, which are common. One is dextrocardia. It is the specialty here is the dextrocardia is the most common positional abnormality of the heart. Okay, it is the most common positional abnormality of the heart, and it occurs whenever the heart tube bends during the development of heart bending or looping, which is occurring in between day 23 and 28. If this bending, instead of occurring to the left, if it occurs to the right, so it displaces the heart to the right side of the body. Okay, as we all know, when the heart develops, normally it lies more on the left side, but in dextrocardia the positioning of the heart is reversed. The heart is located more to the right. Okay, so this is dextrocardia. The next is ASD. Atrial septal defect is actually a normal thing when it is present during the fetal development, but after the birth, if it persists, okay, it leads to what we call cyanotic heart disease. Okay, ASD, VSD and TF. So what happens with these diseases? Acyanotic heart disease, ASD, VSD, and we have PDA, which are acyanotic heart diseases. And why this occurs, ASD? Due to the persistence of foramen ovale. So ASD allows left to right shunting of blood. Okay, so oxygenated blood from the left atrium, okay, is able to flow into the right atrium, and it mixes with the poorly oxygenated blood on the right side. Okay, and now this condition, sometimes when we look at ASD, if there is a patient with ASD is not highly symptomatic. Okay, and if there is a tiny foramen ovale which is which may fuse later in life, okay, it's not a big threat. But if it is reaching to a stage of symptoms and complications and infective endocarditis as such, we should treat this atrial septal defect. And next is VSD. Similar to ASD, it is a bit like the defect is one of the most common congenital heart disease. Like almost 25% of the cases are because of the VSD. Okay, when you see a congenital heart disease, the problem with the VSD is the ventricles are high pressure systems. The ASD is okay, it's a tiny minimal pressure, 10 mm or 12 mm, but here you will see it 120 mm Hg pressure. At this high pressure, all of the oxygenated blood, it enters into the right ventricle from the left side. So it is a left to right shunt again. And this most VSDs, they occur in the membranous part of IV septum. Okay, they are also seen in conditions like Down syndrome. Down syndrome. Okay, so one of the associated condition with VSD is Down syndrome, and one of the more it is one of the most common congenital heart disease, and most of the VSDs occurs in membranous part of IV septum. So try to remember these three important parts of IV septum. And next is PDA. What is PDA, or patent ductus arteriosus? See, in this condition, in this heart condition, you will see a continuous murmur, and it's a left to right shunt. When it comes to clinical anatomy, okay, usually after the birth, the ductus arteriosus, it closes and it forms ligamentum arteriosum. Similar to foramen ovale, there is a connection between what we call the pulmonary artery, okay, and also aorta. So this connection between the pulmonary artery and aorta, it fuses immediately after birth, forming the ductus arteriosus is converted into ligamentum arteriosus. If this fails, what happens? From the high pressure aortic system, the oxygenated blood flows into the pulmonary artery, and the patient will have left to right shunt, congestive heart failures, upper respiratory tract infections, stunted growth, okay, short abnormal growth, and the most important thing here is the patient will present with a continuous murmur, or PDA. Okay. Next is TOF. We also call it as tetralogy of Fallot. Okay, so all these ASD, VSD and PDA, these are all left to right shunts. That means the oxygenated blood from the left side is going to the deoxygenated blood. So patient will not have any cyanosis problems. But tetralogy of Fallot is right to left shunt. So whenever the pressure in the right side of the heart increases, in the same shunts, in the same openings, the blood is now reversed. Okay, so these kind of conditions is known as Eisenmenger syndrome. Okay, Eisenmenger syndrome is reversal of the blood flow. Instead of left to right, now we have right to left. Okay, that is Eisenmenger syndrome. Similarly, we have a congenital condition in which there is a right to left shunt, and this condition is known as tetralogy of Fallot. So when I say tetra, there is a tetrad. So what are the four features of TOF? You have to mention it. They are pulmonary stenosis, okay, that is infundibulum pulmonary stenosis, and second is VSD, ventricular septal defect. Third is aorta, that is overriding aorta, and fourth is right ventricular hypertrophy. Okay, so what happens? Let me tell you the mechanics here. So we have a pulmonary artery from the right ventricle. This is the right ventricle, this is the left ventricle, and we have a VSD here, and we have the tricuspid and the mitral valves here. See, if there is a right ventricular hypertrophy, why there is high right ventricular? Because of pulmonic stenosis. So there is a stenosis in the pulmonary artery, and because of the pulmonic stenosis, there is a right ventricular hypertrophy because the heart is working hard to compensate this. So in turn, the pressure increases. Actually, if there is a VSD, the VSD should allow the blood passage from left to right, because the left side of the ventricle is high pressure system. So blood always moves from high pressure to the low pressure. But problem here is because of increased pressure here due to pulmonic stenosis, and also there is a overriding aorta which is very close, so that whatever blood is now, because of the high to low, it is directly going into the aorta, and this right sided blood is deoxygenated. So now this deoxygenated blood is easily getting into this overrided aorta, and the body will develop cyanosis. When I say cyanosis, the most common cause of cyanosis in early childhood is tetralogy of Fallot. So we are done with dextrocardia, ASD, VSD, PDA, which are left to right shunts, are acyanotic heart diseases, and we are also done with the cyanotic heart disease, that is tetralogy of Fallot. We are left with four more common congenital anomalies. One important one is Epstein anomaly. Okay, in Epstein anomaly, what happens? The problem is with the right side of the heart, we have a tricuspid valve, right? Okay, and in Epstein anomaly, what happens? There is atrialization of right ventricle. Try to remember this keyword. Just write it. Atrialization of right ventricle. See, what separates right atria from right ventricle? So the separating factor between the right atria and right ventricle is the tricuspid wall. So below the tricuspid wall, it is right ventricle. Above the tricuspid wall, it is right atrium. What if the tricuspid wall moves downwards into the right ventricle? So when it moves downwards, the new place is this, and this part of the ventricle, which is actually ventricle, because of the abnormal position of the tricuspid walls, now they are becoming atrialized. So we call this as atrialization of the right ventricle, which is seen with Epstein's anomaly. So the anterior leaflet of the tricuspid wall, it tends to enlarge, it tends to displace downwards, and this leads to the tricuspid regurgitation. Okay, and this in turn leads to dilatation and also the dilated right atrium. Okay, dilated right atrium, and eventually the valvular dysfunction leads to the right heart failure. So this is how the clinical presentation of Epstein's anomaly, that is, the patient will have TR, right atrial dilatation, and right heart failure. The next clinical condition, the congenital anomaly, is transposition of great arteries. Actually, aorta arises from left ventricle, pulmonary trunk arises from right ventricle. But in transposition of great arteries, the relationship is reversed. Now the aorta arises from the right ventricle, pulmonary trunk arises from the left ventricle. Okay, simple. This is called transposition of the great arteries. Next is total anomalous pulmonary venous return. Okay, so pulmonary veins, where do they open? They open into left atrium. But due to defective development, if they open into right atrium, then we call it as a total anomalous pulmonary venous return. Aortic stenosis is simple. Okay, at the entry we have aortic walls into the aortic valve. If there is some issue with these walls, it causes aortic stenosis. It's simple and easy. So these are the congenital anomalies associated with the heart. So let us conclude the discussion of heart, its embryology and anatomy, by finishing most important topic again, that is the anatomy of right atrium. We already have a clear idea of how the right atrium develops. We all know there are two openings. One is superior vena cava and the other is inferior vena cava, and one more opening is the coronary sinus. Okay, and there is a tricuspid wall, and the deoxygenated blood from the body with the help of vena cava enters the right atrium, and through it enters into the right ventricle. Okay, so right atrium is the right upper chamber of the heart, and it receives venous blood from the whole of the body, and it pumps into the right ventricle through the tricuspid opening. Okay, and it also forms the right border and a part of upper border of the heart. Okay, what are the external features then? Very important. When it comes to anatomy of the heart, let us look at the external features. The chamber is elongated vertically. Okay, and it receives blood from the superior vena cava and also the inferior vena cava, and the upper end of this elongation is prolonged to form the right auricle. Okay, this is the upper end, and we have prolongation of the upper end leading to an appendage. So the appendage of the heart is auricle. We have a right auricle. And what does the right auricle does? The right auricle, it covers the root of the ascending aorta. Okay, it covers the root of the ascending aorta, and it also partly overlaps the infundibular part of the right ventricle. Okay, so that is how it functions, the right auricle. The next part is along the right border of the atrium, there is a shallow vertical groove which passes from the superior vena cava above to the inferior vena cava below, and this groove is called sulcus terminalis. Okay, try looking at the image. We have a groove like opening. Okay, it's not seen here. Externally, from the right border of the atrium, it passes from superior vena cava to the inferior vena cava, and we call it as sulcus terminalis. It's an external finding. Okay, and it is because of the crista terminalis, which is present internally. So the internal counterpart is crista terminalis, and it's a muscular ridge extending from superior vena cava opening to the inferior vena cava opening. Try to close this heart. So externally you will observe this sulcus terminalis. So these are two counterparts. One is sulcus terminalis and other is crista terminalis. And what are they? They are a muscular extensions from the superior vena cava opening to the inferior vena cava opening. And next important thing is, we all know that the right atrium contains most important for conductive system, that is SA node, the pacemaker of the heart. And where it is present? It is present in the upper part of the sulcus terminalis. Okay, and it is the pacemaker. The last point when it comes to the external features of the right atrium are the right atrioventricular groove is present, which separates the right atrium from the right ventricle. Okay, so now let us look at the openings or tributaries or inlets of the right atrium. Only few things we know. There are few things which you need to know. Yes, superior vena cava, inferior vena cava, coronal sinus, they all open into it. Along with that, there are other openings like Thebacean veins, the cardiac veins, and the marginal vein. So this is more of arterial system, venous system, which is like from the body, and this is venous system of the heart. Okay, just mention these. The tributaries are inlets of the right atrium. So this will conclude our discussion on the heart. So we discussed the development, the congenital anomalies, and the anatomy of the right atrium. Hi doctor, let us discuss about the development or formation of placenta in a stepwise manner. First and foremost, the two important components which help in formation of placenta are, one is trophoblast and the other is decidua basalis. So they together form the placenta. The trophoblast part comes from the fetal side or the fetus, whereas the decidua basalis is a component of the maternal endometrium, or this is the maternal contribution. Let us see how they help in formation of the placenta. To begin with, the first part is fertilization. So once fertilization occurs, by the time the fertilized ovum, that is the zygote, reaches the uterus, why it goes to the uterus? So that it can get implanted there. Before the process of implantation, by the time the fertilized ovum reaches the uterus, it is already in the stage of morula. Morula because mulberry-like cells are cell divisions. So this morula is covered by a layer of cells known as trophoblast. You need to understand one thing here. The trophoblast has a property of stickiness. That means it sticks to whatever it comes in contact with. But till the time it reaches the uterine fundus, it is covered by a layer known as zona pellucida. At the time of implantation, the zona pellucida, which is the covering around the trophoblast, it disappears, and now the trophoblastic layer invades into the uterine endometrium. So this process is known as implantation. Once after implantation, there is next reaction called decidual reaction. That is, the uterine endometrium after the implantation is in secretory phase. So the first 14 days of a cycle are proliferative phase. At the 14th day, ovum is released, that is ovulation occurs, and by the fertilization in the next 5 to 6 days, by 21st, there is a secretory phase. So this point of time, the secretory phase, the stroma of the endometrium, the cells, they enlarge. So the cells, they enlarge, they form vacuoles inside it, that is they are vacuolated cells, and these vacuoles, they store glycogen and lipid. So why this glycogen and lipid is important? it provides nourishment. So the decidual reaction. So the endometrial lining is now transformed into decidia, and this decidia provides nourishment to the embryo until the definitive placenta is ready. So once the mature placenta is formed, placenta will provide the energy and nourishment, but before that the decidual layer of the uterus takes part in providing the nourishment. So this is the myometrial part of the uterus, okay, and we have the implanted the fetus, that is we have yolk sac, amnion cavity, we have a notochord here. See, this embryo is covered by the chorion, and this has a trophoblastic layer, and it is into the endometrial layer of the uterus, and the endometrium is transformed into decidia. So this dotted area which is shown here is the decidia. This decidia is divided into three parts. So what are the three distinct parts of the decidia? They are characterized, that is they are divided based on the relation to the site of implantation. Most important thing which is taking part in formation of the placenta among the three is decidia basalis, or we also call it as decidual plate. This is the maternal portion of the placenta here. It is very firmly attached to the chorion. This area, decidia capsularis, is the decidia that grows over the blastocyst after implantation, and it is giving, so this is the blastocyst, and it is giving a cap-like structure to it. So this is capsularis because it looks like a cap over the blastocyst. And the third part is decidia parietalis. This decidia, it lines the pregnant uterus elsewhere than the site of the implantation. So at the site of implantation we call it as decidia basalis, and the remaining portion of the decidia which is attached to the uterine wall, leaving this part, that is leaving the implantation site, the rest of this decidia is known as decidia parietalis. So we are discussing the process or the formation of the placenta, and we're done with the fertilization, implantation and the decidual reaction. So once the decidia is ready, the next is formation of chorion, and the later formation of the chorionic villi, and this chorionic villi has primary, secondary and tertiary stages, and this finally transforms into the placental stage. So let us discuss all these steps now. To begin with, we all know that the trophoblastic part is the one which is dividing the fetus from the decidia, that is from the mother part, the fetal part is separated by the trophoblastic layer. So here in the image, this is the trophoblastic basement membrane. Above the trophoblast, the cell division occurs, and the dividing cells, the first layer of the trophoblast is a unicellular layer with a single nucleus, and this part is known as cytotrophoblast. The cytotrophoblastic cells, they proliferate and they form extra layers on top of it, and these extra layer of cells, they coalesce together and they form a syncytium like substance wherein you will see a multinucleated structure. That means the cell membranes of these top layers, they disappear. So disappearance of the cell membranes leads to fusion of all the cells together, and it looks like a syncytium, and now we call this layer as syncytiotropoblast. So the same trophoblastic layer is now divided into two different parts. One is trophoblast, that is cytotrophoblast. The topmost layer, which is multicellular, is syncytiotropoblast. So let's try to understand the difference between cyto and syncytiotropoblast in detail here itself. Cytotrophoblast, the cells, they lie near to extra embryonic mesoderm. So they lie to mesodermal layer of the fetus. Whereas syncytiotropoblast, it lies close to the decidia, that is the uterine part. So for the mother side, syncytiotrophoblast is closest. For the fetal side, cytotrophoblast is closest. The syncytiotrophoblast, the cells, they lose their boundaries as I already discussed. But the main function of the syncytiotrophoblast is it secretes hormones, mainly human chorionic gonadotropin, which is very important to support pregnancy. What is the function of the cytotrophoblast then? The cytotrophoblast, initially it aids in implantation by secreting proteolytic enzymes. So later the syncytiotrophoblast forms, but initially the cytotrophoblast, it helps in process of implantation by secreting proteolytic enzymes. Within the layer of syncytiotrophoblast, later there is formation of the lacunae and there is formation of the trabeculae which separates lacunae. So the further structure leads to development of the chorion and the chorionic villi. So the trophoblast changes. So what are the trophoblastic changes? We have syncytio and cytotrophoblastic development, followed by formation of the lacunae or trabeculae inside the syncytiotrophoblast. The next step for discussion is formation of the chorionic villi. Look at this image. You can clearly see the chorion and decidia basalis in close proximity. But all around the chorion, there is formation of the chorionic villi. So how does chorionic villi develop? They are finger-like projections developing from the trophoblast. You take an example of trophoblast. So this layer, the first layer of trophoblast is cytotrophoblast, and on top of it we have a layer called syncytiotrophoblast with lacunae and trabeculae, and beneath this we have a layer called mesoderm. So whenever there is a finger-like projection, initially what happens? Only the syncytio part and the cytotrophoblastic part, only two of these are involved in formation of finger-like structure. So this is called as primary villi. Later what happens? The mesoderm also starts growing into this, forming the secondary villi. Later what happens? Along with the mesoderm, even the blood vessels also they migrate into the mesoderm. So now the fetal blood vessels, they start growing into the extraembryonic mesoderm, and now this forms tertiary villi. So we are discussing the formation of the villi. Initially it is primary villi with only two layers, that is cyto and syncytiotrophoblast. Later it has secondary with three layers. Along with cyto and syncytio, we also have the mesoderm. Later on, there is formation of tertiary villi which has four structures. One is cyto, syncytio, and the third one is, yes, mesoderm. It also has fetal blood vessels. There is another stage in standard books. So this is fourth stage. We also call this as terminal villi, not quaternary, it is terminal villi. What happens during the development? The cytotrophoblastic cells, they start disappearing, and the islands of cytotrophoblast are surrounded by the syncytiotrophoblastic cells. So this is the island, and these are surrounded by syncytiotrophoblasts, and we have intervillous spaces in between. So this stage is terminal villi, and the layer of cytotrophoblast which is remaining is now called Langhans cells. So that is the reason the cytotrophoblastic layer is also called as Langhans cell layer. Just observe the image here. At the time of formation, the fetus will have the chorionic villi all around the chorionic plate. But later, the chorionic plate which is in close proximity to the uterine cavity, the villi disappear, and this part which is smooth is known as chorion villi. Whereas the part which is in close proximity to the maternal decidia, they grow, they proliferate, they form branches. Later they form anchoring villi, stem villi, helping in formation of the placenta cotyledons. So this is known as chorion frondosum, which is in close proximity to the maternal decidia. So this image is depicting the same, the formation of the chorionic villi. You can clearly see the fetal blood vessels, umbilical vein, umbilical arteries and umbilical cords. They are entering into the decidua and they are forming chorionic villi, which has a covering of both cyto, syncytial and mesodermal extensions with fetal blood vessels. After the formation of the chorionic villi, after the trophoblastic changes, the next step is further development, which leads to formation of the mature placenta. This part of the placenta which is shown in the image is actually on the maternal side, and when you look at the maternal side, there are maternal cotyledons which range in number from 15 to 20. They are separated with the help of the septi. Within each cotyledon, what happens? There are so many anchoring villi and their branches. So one such anchoring villus, along with its blood supply, along with its branches, it forms another part known as fetal cotyledon. Please concentrate here, this is important. There are two types of cotyledons. One is maternal cotyledons, which is because of the septa. One is fetal cotyledon, which is a unit of anchoring villus with its branches. So the number of fetal cotyledon is 60 to 100. So of late, let me summarize the discussion. Followed by fertilization, there is implantation with decidual reaction. And then there are trophoblastic changes, formation of the lacunae and trabeculae in the syncytial trophoblast. Then primary, secondary, tertiary and terminal villi formation. And at last, we have mature placenta, which now takes part in providing nourishment and nutrition to the developing fetus. Let us quickly discuss what are the functions of the placenta. Placenta plays main role in exchange of metabolic and gaseous products between the mother and the fetus. So how does this exchange take place? There is exchange of oxygen, water, electrolytes and nutrition, right? The most important thing to be noted is, you take an example of a full-term fetus. He or she requires around 25 ml of oxygen per minute. So if this oxygen transmission or transport from the mother with the help of the placenta to the fetus, if it does not occur, even a short interruption of the oxygen supply is fatal for the fetus, and this function is taken over by the placenta. And the process of transfer or transmission is diffusion. So the oxygen and the gases, they diffuse through the placenta so that they can deliver it to the fetus. Similarly, there is exchange of nutrients and electrolytes, for example, amino acids, fatty acids, carbohydrates and vitamins, because the demand increases as the pregnancy advances. There is also excretion of waste which are occurring in the fetus, and they are getting excreted through with the help of placenta. So there is excretion of carbon dioxide, urea and other waste products which are produced by the fetus into the maternal blood through the placenta. There is also important function called transfer of immunity. As we all know, during the fetal development, at approximately 14 weeks of fetal age, the transmission of immunoglobulins from mother to fetus will start. So when the transmission starts, it is around 14 weeks of development. An important thing to be noted here is the immunoglobulin which is getting transmitted is IgG variety, because IgM is big. It cannot cross the placenta. The molecular weight is very high. So this is IgG which gets transmitted from mother to fetus. The fetus on its own starts producing antibodies, majorly IgM, after birth, but it takes around at the age of 3 years so that it can properly, or new begins, it can achieve the levels of adult. So the adult levels of immunoglobulins are reached at the age of 3 years, and most of the support till that age is from the transfer of antibodies from mother to the fetus. So placenta also acts as a barrier, because many bacteria, many harmful substances, they try to reach the fetus. So though placenta is acting like a barrier, there are some viruses like poliomyelitis, measles, rubella. So what are this? Poliomyelitis, measles, rubella. You take an example of torches. torch infections, they all can cross the placenta. So yes, it is a placental barrier, but it is not a strong placental barrier here. In a similar way, along with the infections, even the hormones can also cross the placenta. The hormones which are present in the body are not in a high levels to cross the placenta and cause abnormalities in the fetus. But those synthetic hormones which are given during the stage of pregnancy, you take example of progestins or synthetic estrogens. The classic example is diethylstilbestrol, which caused phacomelia, which is the congenital anomaly, right? So in these situations, there is a chance of crossing the placenta. So the placental barrier is there, but it is not a strong placental barrier because some of the infections and hormones can cross it. The antigenic barrier, it is very important because with the help of the placenta, both the maternal blood and the fetal blood, they are separated. What happens if they mix together? Let's take the example of Rh negative pregnancy. If mother is Rh negative and the fetus is Rh positive, if there is no placenta and if there is mixing of the blood, this leads to a grave condition called erythroblastosis fetalis, okay, or immunohemolytic disease of pregnancy. So the placenta has a major function. It acts like an antigenic barrier. Next, very important function of the placenta is it helps in synthesis of the hormones. So what are all the hormones which are synthesized by the placenta? Placenta majorly synthesize pregnancy supporting hormone. What is that? Progesterone. In the initial 2 months of the pregnancy, the progesterone which is supporting the pregnancy, the major amount is actually synthesized by corpus luteum. And this corpus luteum function is supported by another hormone synthesized by placenta, that is human chorionic gonadotropin. So the same human chorionic gonadotropin is excreted in the urine, and the measurement of this HCG on the pregnancy testing kit will tell a lady whether she is pregnant or not. So the other hormone is human chorionic gonadotropin. This major function is it supports corpus luteum so that the progesterone, that is the pregnancy supporting hormone, is released. But after 2 months, the major support is by the progesterone which is released by the placenta. So even if the corpus luteum is not present after 2 months, the placental progesterone can take over it and can support the pregnancy till the term. And the other hormone which is synthesized by the placenta is, we discussed both progesterone and human chorionic gonadotropin. The next is estrogen, very important. And which form of estrogen it is it estradiol or estrone or estriol? This is estrone, this is estradiol, and this is estriol. You all need to know one thing. It is the E3 form, estriol form, which is the major form of estrogen during the time of pregnancy. And what is the main function of this estrogen which is synthesized during pregnancy? It helps or it supports the uterine growth and also the development of mammary glands. So the both uterine growth and mammary glands, very important to support pregnancy and later on for lactation. So the main function of estriol is uterine growth and the development of the mammary glands. So we're done with progesterone, we're done with estrogen, we're done with HCG. The fourth very important thing is human placental lactogen. And what is the other name for it? The other name for it is somatotropin. See, this human placental lactogen is like a growth hormone. And its main function is, as we all know, the glucose is very important for growth of the fetus. The glucose from mother should go to the fetus. And what happens, the mother also has insulin, mother also requires glucose. What does insulin of the mother does? Whatever glucose is present in the mother, it is taken up by the muscles and also the body parts of the mother itself. If there is any anti-insulin like substance which is produced during pregnancy, what happens? Glucose stays. So this will produce a diabetogenic condition. So whenever this diabetogenic condition is produced, the blood glucose of the mother is high. So if the blood glucose levels are high, it can easily go to the fetus. through the placenta. So this function, this anti-insulin, this diabetogenic function is taken over by human placental lactogen or somatotropin. This is very important MCQ. So this diabetogenic function is by somatotropin. There is other function for somatotropin. It also helps in breast development so that the milk production can occur, but the major function it is growth hormone, like it is anti-insulin and it is diabetogenic. So carbohydrate metabolism is also an important function. That is what we discussed just now, the HPL, human placental lactogen. It also helps in carbohydrate metabolism. So this will conclude our discussion on the functions of the placenta. Let me summarize them. It helps in exchange, it helps in transfer of immunity, it acts like a placental and antigenic barrier, it also helps in hormonal synthesis, and with the help of human placental lactogen, it also plays a major role in carbohydrate metabolism of mother. Let us discuss about the anomalies of placenta. So this topic is dealt under 5 headings. So we will be discussing abnormalities based on the number, on structure, and also the attachment of umbilical cord, abnormal positions, and we'll conclude the session by discussing about the adherent placenta. When it comes to number, usually placenta is a single lobed structure, but sometimes 2 or more lobes are seen in the placenta. If the second lobe, that is also known as accessory lobe, this is an additional lobe which is actually located few centimeters away from, we'll call it as the mother placenta. So the baby placenta or the lobe is located a few centimeters away and it is deriving some part of the blood supply, see. So this accessory lobe gives the name the accessory placenta or placenta succinturata. Why it is important to diagnose this condition? Because it is associated with complications like placenta previa and vasa previa, which leads to antepartum hemorrhages, and also this can later, because of the retained segment or lobe of the placenta, can cause postpartum hemorrhage. So because there is a retained bit of fragments or lobes, later it can also cause perfural infections. So this part or this anomaly of the placenta is associated with complications which I just mentioned. And the next is bilobed placenta. You can clearly see 2 placental lobes with an umbilical cord attachment. So in the right part, you can see in this image there are 3 placental lobes with the umbilical cord attachment. Because they are in close proximity to each other with a common connection, the chances of complications are nil or less in these conditions. So we also call bilobed placenta as placenta bipartita, 2 partitions, and this part, trilobed placenta, is called placenta tripartita. So 3 partitions here. So these are most commonly seen in twin pregnancies or multiple pregnancies. So now let's see the abnormal structure part. You should have a basic knowledge about the development of placenta to understand this. So I'll not be going into the details of it, but first thing is placenta membranaceae. Usually what happens, chorionic structure leads to formation of the chorionic villi. And the chorionic villi, which are in close proximity to the deciduum of the mother, the uterus, they remain and they are called as chorion frondosum. Whereas the remaining part of the chorion, which is in close proximity to the uterine cavity or the uterus, it degenerates and forms a smooth structure called chorion leve. So what you need to understand is, if this chorionic leve part, if it remains, placenta may also develop along the walls of the uterus or the uterine cavity. This kind of development of the placenta, see, normally the placenta is just in proximity here, but it is developing along the walls, and this is known as placenta membranaceae. So it is a type of placenta in which the whole of the chorionic sac is covered by a functional placental tissue. And next is circummarginate placenta. This is also a structural abnormality. Usually, see, umbilical cord is attached at the fetal end. We'll call it as chorionic plate. Because the mother end, we call it as decidual plate. The opposite side which you can't see here. But this part is the chorionic plate and this is the fetal end. And the chorionic plate usually should extend till the margin of the placenta like this. But here what is happening? It is not extending till the margins, and there is a ring of membrane like structure. A ring of membrane or which is flat is present around the edge of the disc. So this is circummarginate placenta. Is there any complication associated with this kind of placenta? No, this is not a dangerous one, or it does not have any adverse outcomes. Okay, so this is circummarginate placenta. So next part of the discussion is again the abnormal structure, but here you will see the ring of chorionic plate is bigger than the circummarginate one. So the chorionic plate here is very small, that is, it is unusually small, and this extra part, this part is usually covered by the extrachorionic placental tissue. The extrachorionic placental tissue, it covers this big ring which is surrounding the chorionic plate. As I told you, the circummarginate placenta will not have any adverse outcome, but the circumvallate placenta is prone for premature separation because of very thin structure and very small structure. So the placenta may show premature separation, which leads to antepartum hemorrhage. So yes, it is a dangerous one to have. Next is the abnormal attachment of the umbilical cord. Usually the umbilical cord, as shown in the previous image, is attached in the middle of the placenta. If it is attached at the margin, we'll call it as the battledore placenta. You can see normal location is this, but here it is attached at the margin, so we call it as a battledore placenta. Next abnormal attachment of umbilical cord is velamentous insertion or velamentous attachment of the umbilical cord. What happens in this condition? The cord here, instead of attaching to the chorionic plate, it is attaching to the amniotic sac or amniotic cavity. So what is the problem with velamentous insertion? It should usually attach in the center of the chorionic plate. But what is happening here? It is not even attaching to the margins. It is actually attaching very far away to the amniotic membrane. And now from here, instead of cord, the umbilical vessels are traversing through this amniotic cavity like a bundle of branches covered with amnion, and then they are getting inserted into the chorionic plate as a separate network. So this is velamentous insertion, and the problem with this velamentous insertion is it can cause a condition called vasa previa. Next is about abnormal position. The usual site of attachment of the placenta is on the posterior side in upper uterine segment. But if the placenta is getting, this green color is lower uterine segment and brown color is upper uterine segment. So if placenta is attaching in the lower uterine segment, we call it as the placenta previa. So this condition, because it is attaching into the lower uterine segment, it may lead to antepartum hemorrhage. So this is placenta previa, and this is categorized into different stages or grades or degrees. So three works: degree, stage, or grades. So what are the different grades of placenta previa? Stage 1 is, or grade 1 is, low-lying placenta. The first part of the definition is attachment to lower uterine segment, that is fixed. So the second part of the definition is this placenta in the lower uterine segment is not reaching the edge of the internal os. See this. In the first part, internal os, and this is the placenta. It is not reaching to the edge, but in the stage 2 it is reaching to the edge. In the stage 3 it is covering the edge, and in the stage 4 it is crossing the edge of the internal os. It is going to the opposite side and it is attaching there. So these are the different stages. Stage 1 is low lying, stage 2 is marginal because it is just reaching to the margin of the internal os. Stage 3 is partial because it is partially covering the internal os, and stage 4 is total because total covering and it is reaching to the opposite side of the lower uterine segment. So these are the different stages of the placenta previa based on the abnormal position of the placenta. So we are done with the 4 parts, that is abnormal number, abnormal position, abnormal attachment of the umbilical cord, and the abnormal structure. Now this is adherent placenta. So what happens here? Placenta is in close proximity and it is attached to the decidual plate. Instead of that, if placenta attaches to the myometrium of the uterine wall, then it is called as adherent placenta. So take this name as placenta accreta. Placenta accreta just denotes that the placenta is abnormally attached. That is, the other name for adherent placenta is placenta accreta. Based on the depth of invasion into the myometrium. Let us say if it is just attaching to the myometrium, it's fine. From the attachment, if it is only reaching to less than 50% of the myometrium, the attached placenta, which is abnormally attached, if it is penetrating the myometrium and if this penetration is less than 50% into the wall of the myometrium, we call it as increta. And if this penetration is even more severe and it is crossing more than 50% of the myometrium, then this is known as placenta percreta. So when I say adherent placenta, it goes without saying it is accreta, and based on the myometrial invasion, if it is less than 50%, it is increta. If it is more than 50% into the myometrial wall, it is placenta percreta. So this concludes our discussion on the anomalies of the placenta. So let us understand the concept of coronary dominance now. So there are few previous questions which are asked in the similar concept. One is draw a diagram to depict the blood flow in left versus right coronary artery. And one more question is describe the coronary circulation of heart and add a note on its applied anatomy. And give an account of blood supply of the heart and a brief note on its applied anatomy. So this looks like an important question. The objectives of this session are, let us begin the session by understanding the anatomy of the coronary arteries and the concept of coronary dominance. I'll also give you few applied anatomical aspects of coronary circulation. There are 2 arteries arising from the ascending aorta. One is the right coronary artery and the other is the left coronary artery. So 2 main arteries are right and left coronary arteries. You can see here the right and left coronary arteries. They take origin from aortic sinuses. What is this aortic sinus? You are aware of the fact that there are aortic and pulmonary valves which are semilunar valves. They have 3 cusps. Okay, so let us take the example of an aortic valve. Aortic valve also has 3 cushion-like cusps, and these are the cusps are placed like a shallow spaces. So when you take one cusp, the shallow space enclosed by that aortic valve is known as, this space is known as aortic sinus. When it comes to the aortic valve, there are 3 aortic sinuses as it is a triple valved structure. And these sinuses are named, one is anterior aortic sinus. Okay, this is anterior aortic sinus. The other 2 are the left posterior and the right posterior aortic sinuses. If you know what is aortic sinuses, it becomes easy to understand the origin of the right and left coronary arteries. When it comes to right coronary artery takes origin from the anterior aortic sinus. What is that? It is anterior aortic sinus. And after taking origin from the anterior aortic sinus, it runs in between the right atrium and the pulmonary trunk, and at the junction of right border of the heart, this is the right border and this is the inferior border of the heart. At the junction of right and inferior border of the heart, it takes a turn to the posterior aspect. And what are the two major branches? There are few minor branches also, but for exam point of view, you should remember that there are two major branches of the right coronary artery. One main branch which is going to the posterior surface is posterior interventricular artery. What is that? Posterior interventricular artery. The other name for this posterior interventricular artery is posterior descending artery. Just keep this PDA sentence in mind because this has relation to the concept of coronary dominance. Next thing is, the other branch of right coronary artery is the right marginal artery. What is this? The right marginal artery. Now, after understanding the origin, course and branches, let me quickly give you what is the area supplied by the right coronary artery. The area of supply is predominantly, so right atrium and major part of the right ventricle, and the one point, the take home for you is, it predominantly supplies the conducting system of the heart. So you know the conducting system of the heart. AV node, SA node, Purkinje fibers, bundle of His. So this is conducting system of the heart is actually supplied by the right coronary artery. Let us now discuss the origin, course and branches of the left coronary artery. Left coronary artery takes origin from, what is this? The left posterior aortic sinus. What is that? Left posterior aortic sinus is the site of origin from left coronary artery. After the origin, it runs in between the left atrium and the pulmonary trunk, and after that it divides and gives rise to, yes, there are many branches, but for exam point of view, here you need to remember two major branches. They are the one which is going towards the posterior surface, that is the left circumflex artery, and one which is continuing anteriorly, this is left anterior descending artery, that is LAD, or left anterior interventricular artery, that is anterior interventricular artery is the other name for left anterior descending artery. So this is LCX, that is left circumflex artery, this is LAD, that is left anterior descending artery, and this is PDA, posterior descending artery. These three branches of the coronary artery are important when it comes to clinical aspect, because these are the three major branches which are involved in coronary artery blockage. When it comes to the supply of the left coronary artery, the LCA mainly supplies left atrium and major part of the left ventricle. When it comes to conducting system of the heart, in 40% of the cases, the sinoatrial node, what is that? SA node is actually supplied by the left coronary artery. Along with that, the left bundle of His, what is that? The left branch of bundle of His is actually supplied by the left coronary artery. There are some minor variations, but you need to remember these few important points when it comes to exam. After understanding the coronary circulation, let us get into understanding the coronary dominance concept. You can see in the image, there is a pink colored distribution and the red colored distribution. So the red color is about the left circumflex, that is the left side of the artery, left coronary artery, and the pink distribution is about the right coronary artery. Now, I'll give you some facts. 80% of the cases, 80% of the heart is a right dominant heart. So, in 80% of the population, the heart is right dominant. Okay? In 10% of the cases, the heart is left dominant, and the remaining 10%, the heart is codominant. So these are just facts. Now let us try to understand what do they exactly mean. When I say right dominant, the right coronary artery gives rise to posterior descending artery, and this posterior descending artery is major artery which supplies AV node. Just remember this process or this flow. RCA giving rise to PDA and it is supplying the AV node. When I say left dominant, that is in 10% of the cases, the PDA takes origin from left coronary artery. So instead of right coronary artery giving branch, now the left coronary artery is giving a branch known as the posterior descending artery, which is actually supplying the AV node. In 10% of the cases, that is codominance, the PDA is taking origin, that is both right coronary artery and the left coronary artery, they are giving branches to the PDA. So they go and supply the AV node. Now I'll give you some sentences. If the AV node is getting blood supply from the left circumflex artery, why I'm saying LCX? Actually the branch of LCA which is giving rise to PDA is left circumflex. If in a person the PDA is a branch of LCX, then that person is left dominant. If AV node is getting blood supply from the right part, that is right coronary artery, then it is the right dominant. Okay, just you have to remember the posterior descending artery, the branch, so from which the origin of PDA decides whether the heart is right or left dominant. In the image, that is what is shown here. See, this is right dominant. The pink color is actually giving rise to the posterior descending, but here the red colored arteries are giving rise to the posterior. Red means the left circumflex artery. So after understanding the concept of coronary dominance, let us see few applied anatomical aspects of coronary circulation. As we all know, heart supplies the major part of blood supply to different organs is from the heart. But heart is getting its own blood supply with the help of coronary arteries. And because heart being a vital pumping organ in the body, even a minimal blockage, because coronary arteries are small vessels, even if there is a minimal blockage in the coronary arteries, that leads to, if the blockage is incomplete, that leads to ischemic kind of chest pain in case of stress and during exercise. So that condition is angina or angina pectoris. What do we see in angina or angina pectoris? There will be chest pain. And one take home for you is, in angina, the blockade of coronary artery is incomplete. If that blockade is complete, and if there is complete blockage of blood supply to the myocardium, myocardium undergoes necrosis, and this condition is known as myocardial infarction, otherwise known as heart attack, which is the most common or leading cause of death worldwide. And why there is myocardial infarction? Due to complete blockade of the coronary arteries. And whenever if a patient presents with a chest pain and you are suspecting a cardiac cause, if you want to confirm that there is either an incomplete or a complete stenosis of the coronary artery, we do a test known as coronary angiography, which is an invasive procedure. And what is done in coronary angiography? We are injecting dye into the coronary circulation so that we can look into the branches, the distribution, and wherever there is a stenosis, that is clearly seen, because coronary angiography is a highly sensitive invasive procedure to look into the coronary artery anatomy. And these two may see, let us say that there is a patient with coronary artery blockade, and if the patient presents to you within like 120 minutes of window period, we can retort to few procedures of reperfusion. One is percutaneous angioplasty, otherwise known as PCI, percutaneous intervention. We do stenting, okay, stenting of the coronary circulation. Let us see, this is a left anterior descending artery, and if there is a blockade here, we place a stent inside the vessel, and this is for the sake of reperfusion. So we do PCI procedure. Similarly, if the procedure can't be handled with a PCI, we can resort to a procedure known as coronary artery bypass grafting. So what is this procedure? Here, instead of using an artificial stent, we replace the stenosed vessel with a bypass graft. And what are the two major blood vessels which act as a graft? One is great saphenous vein. So the great saphenous vein is commonly used as a graft. The other is internal thoracic artery. So these are the two blood vessels which acts like a graft. See, there is a statement here. MR means mitral regurgitation. So what is this? MR means mitral regurgitation. Why MR is more common with posterior descending artery infarct? So let us not confuse the topic. My statement is MR is more common with PDA infarct. PDA means posterior descending artery. What are the other two arteries which I told you? Left anterior descending artery and left circumflex artery. You know, the most common artery to undergo infarction, that is the blockage, is left anterior descending artery. And most of the cases of heart attack are because of blockage in the left anterior descending artery. And this artery is otherwise known as widowmaker. Interesting, right? Widowmaker, because this is the most common artery which leads to death in males. Okay, making females the widows. That is why LAD blockage is widowmaker. Along with that, the LCX and PDA are also involved in few cases of the coronary artery disease. Now, my statement is mitral regurgitation is more common with PDA infarction. Why? Because you need to understand a concept of blood supply to papillary muscles. So what are papillary muscles? Papillary muscles are actually present in the wall of the ventricles. And what is their prime function? Their prime function is, see, this is the left ventricle. Because I am talking about MR, that is the mitral regurgitation, that is mitral wall. Mitral wall is actually present in the left part of the heart. So this left ventricle has muscles known as the papillary muscles. And their function is, what is the function of papillary muscles? They give support. What do they do? They give support to the mitral wall. And these papillary muscles are two types. One is the anterolateral papillary muscles, which are present anterior and lateral, and the other is posteromedial papillary muscles. While we are discussing about the coronary circulation, the left coronary artery, right coronary artery, and their distribution, there is one interesting circulatory aspect to this papillary muscles. The anterolateral papillary muscles, they receive blood supply from LAD and LCX. Whereas, even though the posteromedial papillary muscle is a part of left ventricle, as I told you, major part of LV is supplied by left coronary artery. But the minor part, that is the posteromedial papillary muscle, is actually supplied by posterior descending artery, which is in 80% of the cases arises from the RCA. So why this concept is important? If there is a blockage of PDA, as we all know, the posteromedial is actually getting blood supply only from single artery, that is the PDA. So if there is any blockage, there is no collateral circulation from the other artery. So that is the reason in cases of left coronary artery blockage, that is LAD or LCX, if there is one blockage, the other artery is available to supply it. So if there is either a LAD infarct or LCS infarct, there is the other counterpart to help them. So you will not see mitral regurgitation. But in cases of PDA infarction, MR is more common because the PDA is the sole blood supply to the posteromedial papillary muscles. So the last applied anatomical aspects before closing the session is coronary circulation occurs during diastolic phase. So the statement is true because during the systolic phase, that is during the phase of ventricular contraction, the epicardial coronary vessels. So let's take this as a ventricular muscle, and inside it we have coronary blood vessels like this, right, on the epicardium. What happens during the systolic phase, during the ventricular contraction? These coronary vessels are in a contracted state. So the blood supply to the myocardium or the wall of the heart will not occur during the systolic phase. What happens during diastolic phase? During diastolic phase, there is relaxation of the ventricular wall. This leads to opening of the coronary vessels. So major part of blood supply to the heart occurs during the diastolic phase. What is the clinical significance of this logic? See, when a patient has tachycardia, When the heart rate changes, the systolic phase of cardiac cycle remains constant. That is, the time period remains constant. When heart rate increases, only the diastolic phase it gets shortened. So that means in cases of tachycardia or in cases of fibrillations, that is ventricular tachycardia, ventricular fibrillation, what happens? Blood supply to the heart gets decreased because of the decrease in diastolic phase. So diastolic phase is the major phase where the coronary circulation takes place. So what is your take home when I say coronary circulation? There are two arteries, and you know the conducting system of the heart is mainly supplied by the right coronary artery. Now you know the origin of the coronary arteries and what is the concept of coronary dominance. At the end, it is important to know the main terminology like angina, MI, coronary angiography, PCI, CABG, and there are two interesting concepts here. Why MR is more common with PDA infection and why coronary circulation occurs only during the diastolic phase. So if you know this much, it is more than enough for examination.